I'd like to welcome everybody to the webinar. We're going to keep it fairly informal tonight. We want people to be able to ask questions. We want to give you kind of our mindset with what's been a very exciting system for us to use. CrossRoads has kind of come up with, we want to have one person in the room to help you with any of these bunion solutions. And they've been working incredibly well in my hands, and I'm very excited about it. I fell in love with the nitinol and the staple plate, which we'll introduce you to. I've had phenomenal success that we're researching now. We'll publish very good results on that. And then the MiniBunion came along, which has been a revelation to me. If we can go to kind of an idea of what we're doing here. The idea is to be ready for whatever bunion you have coming in the room. You don't have to go to a bunch of different manufacturers. And we can fuse the first MTP. We can do a bunionectomy. We can do a first MTC fusion if we like with a lapidus. And they all work pretty nicely. And we want to show you why we're excited about it. Let's see if I can get to something here. There we go. So that's the first thing I started with, a fusion plate, and that's for the lapidus. And this is the MiniBunion. But kind of self-explanatory how they work. So with a moderate deformity, we can do the DynaBunion, and this cutting guide is amazingly easy to use to make your cuts, and then we can correct the deformity as a lot of systems do. This one's easier than anything I've ever used and more controllable. Now what's very cool is then we can compress it, and then we put a plate on. I've been using this plate now for about 3 years, and I've been very happy with it. We just started with a different system. I just started using staple plates for 2-3 TMT. They work pretty well. I've had 100% fusion, my first MTP fusion so far. They work pretty well. And this is the MiniBunion, which we'll go through in a few minutes. And this we call the Viking chip on top to help align things, but basically small incision. We're going to go through some more detail in a few minutes. Basically cut the head, slide it over. And then the key thing was that you stabilize things and then you rotate the head. So this does everything I couldn't do with the chevron. And I've been really happy with it. This is the new hammer toe implants. I've been using a staple. I've added an Aiken a number of times, and there's a new staple for the Aikens we've been pretty happy with. Let's see what else we have in our little show here. I think that's it for this. We can move on to, this is the algorithm that we're basically using. And Lord knows we've all seen enough algorithms for bunions and what to do and what we do at certain times. Certainly for arthritis, I'm a big believer in the first MTP fusion. It's a great solution. The patients function very well. They can even do light running with it. And we've published that it works pretty well. When you have just a regular bunion that's not arthritic, when you do a lapidus versus a MiniBunion, and I think if you have a lot of instability at first MTC joint, I think it's fairly clear most of us would like to fuse that first MTC joint. And we'll use a DynaBunion. If you have a more severe deformity, that's when it's getting very confusing. And that's what I think will enlist the panel to help us figure out. When do you do a bunionectomy? And I'll use the MiniBunion for anything up to about 16 to 18 degrees, sometimes even higher. But for severe deformity, of course, you can just do your lapidus with a DynaBunion technique, which works very well. I think it's worthwhile plumbing people's minds this evening to talk about who does what when. I have a conversation with my patients, and I tell them, if you want to keep it simple, you might get a recurrence of deformity. We can always do the MiniBunion. But when they have instability of the first MC, I'm going for the DynaBunion, and I've had wonderful success with it. With that, we ought to get on to a case. And I think it's easier with these kind of seminars to review a case. So here we have a 42-year-old woman, pain with walking closed-toed shoes, a little bit of pain in her second MTP as well, a little bit of metatarsalgia. She's not yet crossing over. We're not supposed, I didn't do that. Who did that? Okay, there we go. Okay. And so now we want to see what the different panelists would do for this. And I'll hit Dr. Young first. Dr. Young, what would you do in this case?
Well, I mean, I don't see a large deformity, so I usually just check their range of motion at the first MTP. If they've got an easily reducible joint, feel like the sesamoids are going to reduce rather easily, and there's not hypermobility of the first ray, this would be a MiniBunion. Easy for me, easy choice.
How long would it take you to do a MiniBunion procedure, Evan?
After I did 5 or 10, I got it down under 30 minutes pretty easily. I think the shortest tourniquet time was about 18 minutes.
Yeah, I've found it's been incredibly fast, sometimes deceptively fast.
Yeah.
But yeah, it's worked pretty well. And we're going to go through the technique in a little bit, but the hardest thing about the MiniBunion is lining everything up before you make your cut. But I've been pretty happy with the way it's been working out. Dr. Oji, you used to do chevrons for these. What do you do now?
I think this is, I'm with Dr. Young, it's fairly straightforward. I would go with the MiniBunion. I mean, the deformity is very manageable. It doesn't look like there's any instability at the first MTC radiographically. No pes planus. Yeah, I think very straightforward. I don't really do any open chevrons anymore. There's really no need, especially with the newer technology like MiniBunion. You can get that great translation and really restore that nice anatomical position at the MTP joint.
When you said to do a while, David?
Only if they have pain at the second MTP. It doesn't look, I don't know, did you mention this patient had that? It doesn't seem like this patient, I don't think you mentioned it, but.
Briefly in passing, yeah, I did, but that's okay. So she did have pain at second MTP, but it was cocking up just a little bit, not too badly, obviously.
I will probably not. I may actually planiflex that or translate that slightly at the MiniBunion to try to offload that second MTP joint. I've had pretty good success with that.
Dr. Lamm, when do you decide doing a MiniBunion versus some of the other MIS procedures? I figure you're going to do a MiniBunion here because you're on this panel, but what do you think?
Yeah, so I agree with David. I think if you look at that lateral view, it is a little bit elevated the first ray, maybe not, kind of too significant, but maybe a little bit. And maybe that's the reason why she's having that sub-second pain. So as David mentioned, you can planarly translate that transverse osteotomy just a bit. You got to be really critical on those lateral fluoro views to make sure you get the sagittal plane aligned. And so that you could take care of there. I don't see a need to go proximal in this case. I think I'd stay away from an ache, and it looks like you could do the soft tissue balancing, which the MiniBunion plate has that advantage where you can lock in a suture to tighten up that medial capsule.
Okay, so let's see what I did. We can advance. So there we go. I'll go back. There we go. Up, go back, please. Okay, there we go. So there we did a MiniBunion with a wild osteotomy on 2. I think she had some stress reaction on 2 before. We slid that back. And luckily she did fine with it, but it worried me a little bit. Any criticism of this MiniBunion from the panelists? Any concerns, worries? This is 5 weeks out. We already have nice cortication laterally on these.
Yeah,
Dr. Lamm, look okay to you?
Yeah, so the distal screw, you have like 1 cortice, it looks, at least from that view. Maybe it's not a perfect AP view, but I like to grab 2 cortices distally if you can. And then, the angle of the intermedullary device could be more down the shaft, kind of central, like the mid-diaphyseal line. That would get you a little bit more, lateral translation of the capital fragment in general, but it looks like great ossification of the osteotomy there.
Evan, you're going to talk to us about the MiniBunion. Do you get 2 cortices on your distal screw? I hadn't been taught to. That's why I did it this way, but I'm still learning.
Yeah, I always get 2 cortices, and I actually freehand throw that screw about 99% of the time, just to try to get it a little away from 2 parallel with the osteotomy, so that you don't get any sagittal plane toggling of the head. I don't think you got any of that on this case. I guess my only criticism would be if you were trying to get some planar translation, it kind of ended up back in a perfectly parallel position. So.
Well, I learned something. I didn't know I was supposed to get 2 cortices distally, so that helps me. Luckily, she held up beautifully. Again, I was This was one of my early mini bunions, and I was fascinated by just how quickly that cortication took place laterally on when you don't open up those soft tissues at all.
Mhm.
Again, a small incision. Good.
Yeah. Oh, Dr. Miller, I was gonna say, sometimes I don't get two cortices. I find sometimes they have very strong bone. I found that far cortex, it can kind of rotate that capital fragment slightly. So I always put in a screw about 2 millimeters less than what I drill typically, and then that resolves that issue.
Cool. Okay, let's try one more simple case, and we'll get on to the specific discussions. So this one's a little bit easier to decide. A 64-year-old gentleman who had a fracture more than 10 years ago, obviously some sort of Lisfranc variant, who now is unstable. He hurts like heck, but he's very active, and he wants to get back to normal life as soon as possible, but we got to do something. David, what do you think?
Yeah, I mean, it looks like this person most likely had probably a Lisfranc injury, if I had to guess. I mean, the first MTC is pretty arthritic. Looks like the second is also arthritic, maybe third to a lesser degree. Looks like there's kind of pes planus through that midfoot as well. I mean, I would always try conservative management first, but certainly I think given the kind of the long duration and being symptomatic, I think a midfoot fusion is most likely in order for this patient.
How do you say between 1 versus 1, 2, or versus 1, 2, and 3?
Well, I mainly go by symptoms first, followed by how much arthritis they are. I try to fuse as little as possible. But I think in this person, I think you're obligated to do 1 and 2 just from radiographic evaluation here. And a lot of times I get a CT scan to evaluate the lesser MTC joints to just kind of see if there's any resemblance of arthritis or any signs of it. In the third MTC, I would have a very low threshold to fuse that joint.
Dr. Lamm, you always get a CT scan on these beforehand?
Yeah, I like MRIs to look closely for the cystic formation at the the joint level. And I agree totally with David. I think I would approach it the same way with Lisfranc fusion, either 1 or 1, 2, and 3, depending on the MRI. And then I use a clinical test where I kind of hold the cuneiforms with one hand and the other hand kind of move the the metatarsal up and down to try to isolate motion at that second medial or intermediate cuneiform joint, and then the third lateral cuneiform joint to see if I elicit pain. And that's kind of one of the telltale signs I look for as well.
Dr. Young, anything to add? You use the cutting guides on these?
I do use the cutting guides most of the time. I think this one, the biggest thing that's worrying me is the shortening of the first ray. Your sesamoids are almost in the joint. But I know that the DynaBunion cut guides are fantastic at reducing the amount of shortening that you get. So for that reason, I probably would not be afraid to use the cut guides on this one. There's a lot of frontal plane on that. You can see the concavity of the first met. The plantar surface is sort of showing up on the lateral side of the first met. So I think DynaBunion is a great choice on this one. But yeah, I think you definitely need to evaluate the second and third TMT joints as well.
Yeah, I've gone to a flat plate on these cases because I find my first ray is slightly medial to the cuneiform, and I want to level everything off. And I found versus when I used to just use 2 screws, a plate has been much more forgiving for me and much more stable. So I went with a plate. I used to do my own cuts, and I was using the before they had the cutting guides, I was just using the implant without the cutting guides. And of course, I've been teaching this for a long time. I thought I was a pro with the cuts, and now I use the cutting guides all the time. It just makes my life easier. I assume everyone else has the same idea. I mean, I like the easy button here whenever you can.
Yep.
So here we fused it. I didn't have to do any, I decided not to do anything with 2. I figured I'd get enough stability with 1, and they weren't that symptomatic at 2. I do something called, like Dr. Lamm was describing, I do a piano keying up and down. I call it moving and I move the met head up and down in the office. And I see the patient has pain at the TMT joints. And if they don't, I can just do this, and I just take a lot of care not to elevate that first ray. I want to make sure I'm, if anything, plantar flexing it just a little bit. And this X-ray is, I think about 5 or 6 weeks out, maybe even longer. And it looks like I have a little gap there laterally, but it's solidly fused. And I think it's actually a little bit further out. And the patient's completely happy and doing wonderfully.
Did you use the cut guide for this, Dr. Miller?
I think so, yeah.
Yeah, I mean, you could tell there's very little shortening of that array. It's pretty amazing.
And I was a little afraid to shorten it too much, to be honest with you. And because he's so active, and once you start balancing things get messy. But he formed a really solid fusion. So in my first version, first TMT joints, again, I have a 100% fusion rate with this plate. This staple just keeps on compressing, and I think we'll show people that later on. But it's pretty amazing. And I did this before we had the cross screw, but we can show one of those later on. Let's go on to talk about some more things.
Good. All right. So I'll kind of review the DynaBunion and then kind of go over 2 cases. DynaBunion is a 4D minimally invasive or minimally incision Lapidus system. It's a very kind of straightforward system where you use a cut guide to make the osteotomy or the joint preparation, and you can use this radiolucent reducer to correct the IM angle. You can get frontal plane correction. And also you can plantarflex and dorsiflex that first ray. It's reproducible. It's got excellent ease of use. And again, you can get excellent 3D correction of the frontal plane, transverse plane, and the sagittal plane. And you can see this video on the lower right, where you're getting the excellent kind of correction and coverage of the sesamoids through the pins there. The system is reproducible. It does eliminate a lot of the kind of complexity involved with the Lapidus, and it does reduce the time significantly. It's really very simple to use once you get used to it after several times. And you may think you can do your Lapidus on your own, and certainly we've all been taught to do a Lapidus without any assisted devices, but this does make your life much easier. You really don't need any more assistance. You can do this by yourself, honestly. And in addition to the 1, 2, and 3, the transverse correction, the frontal plane correction, sagittal alignment, you can also get compression, which is a really amazing concept. They have this rack block, which is this white block on the right side. And you put that in over the pins and it provides compression and really brings the two kind of the metatarsal and the cuneiform together, and you get excellent bony contact. And then on top of that, you get the Lapidus plate with the continuous nitinol staple compression. And then even on top of that, you get the anti-drift bolt for additional fixation. So it's a very strong construct. You can start weight bearing very quickly, and has a great fusion rate. Some of the new things that they are now bringing out is in the past, the triplane correction device was not radiolucent. The new device is. So that does help in determining where you're putting the pins, and you can see the sesamoids a lot better. Again, the new device with the radiolucent reducer is much easier to use, and does improve the ability to see the frontal plane correction. And then one of the kind of, in the past, the anti-drift bolt was partially threaded. I personally have not had any issues with that, since it is important to drill through all the cortices to the lateral cortex, the second met. But certainly some people do worry about it backing up. So now they do have a fully threaded option for additional fixation and bite. So in review, you can get excellent, the initial DynaBunion is to make your cut. You place the reducer and you get the correction. and then you use the rack block to get compression. And with the nitinol staple in the plate with anti-drift ball, you can get excellent compression, stability, and early weight bearing. So here's a video. Let's see if I can get that to start here. Okay, so you make an incision in the dorsal medial approach. It's critical to use the osteotome to free up the plantar cortex. You put the pins through the cutting block. You make sure that you do bicortical. You can put additional pins for stability. You make your cuts. You remove the small wafer, only 1.6 millimeter. I recommend the pituitary rondure to remove that. It does make it easier. And then you can correct through the frontal plane through using the radiolucent reducer or the IMA angle. You make a small incision on the dorsal aspect. You pin it in place. And then you can now correct the IM angle. Initially, you do the frontal plane correction, and then you do the IM angle reduction. It's critical that you dorsiflex the first ray to activate the windlass mechanism, and you put the pins proximally. You make the cuts to cuneiform thereafter. You remove the cut block, and you remove that small wafer of bone. Here you can then prepare the joint surface. If you need to recut it, you're more than welcome to, or you can freehand cut it. The new sets have a joint distractor to clean up the area. And if you want to prepare the joint surface, you can with fenestration or feathering the joint. Sometimes you don't have to. You get just under you, the cuts can be just underneath that subchondral surface. You place the rack block, which you'll see with this white device. There are different levels of compression you can do. Usually the 0 works just fine. It compresses the two together very nicely. You get excellent bone-to-bone contact. You can leave that in place, and you can plate around that as well. You can also place a K-wire through that for fixation if you're not getting good position of the plate. And once you pin it, I usually use 2 pins. Then you can remove the rack block and put the plate on and fix it again. If there are any ledges or any uneven surface, you can use the grater block to remove it. There are multiple plate options. You can just use the staple, or you can use the Lapidus plate. They do have a very nice plate bender if you do need it, although I have not had to do that, especially with the grater blade. You get a nice even surface. You pin it. You put the staple on first. Typically it's 18-14 staple, with the 14 going proximally, 18 going distally. Once you get the staple fixation, then you put additional screws proximally and distally. The staple is very easy to use. Once you do it once, you'll realize it's probably one of the best staples in the business. Very easy to use and remove. I do non-locking screws proximally and distally. Typically, you get great purchase in all 4 screws. I have not had a need to do any locking screws. Maybe in a very small handful I did in osteoporotic patients. But it is important to just have some or non-locking screws at least on one side so you can get continuous compression. The anti-drift ball placement, it is variable, so you can adjust where you're going to put it. It is recommended you drill through all the cortices, including the lateral cortex, the base of the second metatarsal. And then you can place the anti-drift ball either fully threaded or the partially threaded. All right, so we'll kind of do some cases here. I had this patient, 68-year-old female, past medical history of osteoporosis. She has diabetes, type 2, although controlled, hypertension, worsening pain. She also has pain in the second MTP. She does have a slight pes planus deformity. It is slightly, and she does have a flexible MTP joint. She has no history of neuropathy. Dr. Miller, can you start us off and let us know what your thoughts are and kind of your algorithm in treating somebody like this?
Sure. Yeah. I worry about the big toe. I want to make sure it's mobile. I want to look at it. I want to make sure that I have a salvageable joint. If not, and this one's going to be iffy, I just do a first MTP fusion. Depends how unstable she is at her MTC joint. If it's unstable there and the first metatarsal phalangeal joint looks good, then I'll do the DynaBunion. The second needs a while, probably, or even a resection just to get that joint back in place. But I think I'm going to start off by looking at my first metatarsal phalangeal joint and see if it's salvageable or not.
Got it. How would you, like with MRI, you mean, Dr. Miller, or you mean intraoperatively?
Well, you can do everything you want, but the reality is it depends what it looks like when you get in there. And so that's the beauty of having these systems. My rep has everything in the room for me, and I can decide whether I'm going to fuse it or do a DynaBunion at the time of surgery. And it makes my life a lot easier. Okay, the joint's shot, we do a first MTP fusion, let's do it. And I can ignore the MTC joint. So I do a first MTP fusion and a second while and get away with that, maybe a second hammer toe. If the joint looks great and it's all just instability at the MTC, then I'll do the DynaBunion.
Dr. Young, what are your thoughts?
Yeah, I mean, the history is a little on the concerning side, of course, with the osteoporosis and diabetes. But, you know, I still think with as good as these systems are, I think if the first MTPJ doesn't show any degree of pain and it feels reducible, I'm doing a DynaBunion on that. If it feels stiff or rigid at all at the first MTP, I'm going to fuse that joint instead. I think a while and a hammer toe, you know, plantar plate repair or flexor to extensor transfer additionally, probably all good idea for the second toe.
Dr. Lamm, I mean, I've always had trouble trying to determine, you know, MTP fusion versus Lapidus and somebody like this. She does have a flexible MTP joint. I mean, how do you determine between fusion of the MTP versus MTC?
Yeah, I think if it's, you know, kind of a fixed deformity at the first MPJ, then, and it's not reducible, as Dr. Miller was saying, then it's really concerning that can you get the correction? And so those cases aren't good for the MiniBunion. I've failed in those cases where the great toe isn't reducible back into joint position. And so even if you're doing a lateral release, even if you're doing some shortening, the MiniBunion will be difficult to fix if it's not reducible. So that's kind of my clinical exam. And some of these are still very flexible and can be reduced. And then you can definitely consider the MiniBunion. And on a patient of this age and so forth, I've done very well with the MiniBunions. I just keep them in a surgical shoe a little bit longer than, say, the, you know, patients who are younger, heal quicker, and without comorbidities. So, you know, it's something where maybe instead of 6 weeks in a surgical shoe, or, you know, I'd maybe do 8 weeks if I did the osteotomy. But I think fusion is a great procedure. You can reduce that IM angle, and I wouldn't hesitate if I felt like the joint wasn't salvageable.
Yeah, she ended up having a little bit of instability at the MTC. Her joint was partially correctable, so I did end up doing the DynaBunion on her. This is at 2 weeks post-op, so I did include a Aiken osteotomy. I did have to do a modified McBride and do a formal lateral soft tissue release. A lot of times I don't have to do that. I did shave a very small eminence of the medial aspect and did a full medial plication. She actually had a little bit of a plantar plate still left, believe it or not. So I did repair that with the Z-lens near the EDL in a while. Although that bone was very soft at the second metatarsal head, so I did have trouble fixing it. That's why I have 2 screws in that area. Then this is, oops. I don't have, oh, there was a 12-week, but at 12 weeks, she was fully healed, and she's doing very well from that.
So Dave, you got those sesamoids underneath that metatarsal head in an incredibly good fashion. You just lucky or think it's a rotation?
She had quite a bit of rotation, so I did have to correct that. And the DynaBunion really allowed the IM angle reduction, the frontal plate correction. So certainly the system helped me out quite a bit.
And when did you let her walk on it?
I actually let her walk. I was a little more conservative given her weak bone, so I did actually 4 weeks of non-weight bearing. But typically, I do let them weight bear after 2 weeks, and then at 4 weeks, weight bear is tolerated as they feel comfortable. It doesn't show it on here, but I also this system allows you to kind of plan flex. So I did plan flex that first race slightly. And so I did reduce some of that pes plainness. So she's happy that I restored some of that Miri's angle. Dr. Young, when you do your DynaBunion, when do you, what's your post-surgery protocol?
I asked them to do nothing more than transfer on it for about 2 weeks. They have a boot on for that. And then after their stitches come out, and I feel like, you know, they kind of I have a feel for how they're handling the post-operative swelling and pain and everything like that. Usually I can get them up and moving a little bit more, but I still try to cautiously allow some weight bearing for probably the first 6 weeks.
Got it. Dr. Miller, are you a boot or a shoe, or what is your preference?
That's interesting. You know, I used to be very conservative, and I was non-weight bearing for a month. Then I started walking in a boot. And then especially the boys from Grand Rapids taught me that they were letting their patients walk on their heel right away. And so now I let them, if they're capable and they're agile, I'll let them do weight bearing is tolerated on the heel in a post-op shoe. If they're a big, heavy person who's going to be real clumsy and probably overdo it, I'll put them in a boot to protect them. Let them do partial weight bearing in a boot.
Dr. Lamm, there are some people who advocate for kind of roughing up the base of the first and second metatarsal to try to get some fusion across there. What are your thoughts in trying to get a small amount of spot fusion in that area?
Yeah, I think, you know, this system compared to other systems does have this, you know, screw that allows for, you know, more stability of that medial column, which we have seen recurrences, and that was the reason for this, which I like. So I do spend a little time once I take both cuts out to roughen up that lateral or the medial side of the second metatarsal base to try to get some fusion there. And I think that's key for long term, because if they have hypermobility at one joint and you're fusing that, it's going to try to, you know, move to the next, in my opinion. So I think it's a good feature of the product. Plus, I do try to instill that, you know, synostosis between 1 and 2 and the medial cuneiform.
How do you roughen up that medial aspect of second metatarsal?
Yeah, so I use usually the wires or the drills that come in the set, and just kind of, you know, puncture through that cortical bone to kind of beat it up a bit, and then maybe a little small curette if I feel like I need to do it that way as well. But it's really nice with the laminar spreader or the, you know, kind of opening device that comes in the set, that Hinterman type retractor. It allows you to get in there and see real good, get all the pieces out, and roughen that second met up a little bit.
All right, thanks. All right, here's second case here.
So Dave, one criticism, I think you might have overcorrected that just a little bit. I like, you have almost a 0 or maybe a little bit negative angle there. I know where that came from. And I've criticized Lou about that for many years. I leave them a little bit, just a little bit wider, but I certainly like the way you brought it down a little bit. As Ted Hansen says, to get some stability for that flat foot. Very nice.
Oh yeah, thank you. She did open up a little bit more, so she's not that overcorrected when I saw her back at the 12 weeks.
Okay.
Here is our last, my last patient, 78-year-old female, retired nurse, really just hypertension, pain along the medial eminence. She has no kind of dorsal or plantar joint pain at the MTPJ. She has a second hammer toe as well, but no metatarsal pain at the second plantarly. Dr. Lamm, what are your thoughts and kind of your treatment algorithm for this patient?
Yeah, so, you know, the 78-year-olds, you know, they, in my practice, they're a good candidate to have, you know, I like the MiniBunion in this case. If, you know, it's pretty easy healing, easy procedure for me, easy for the patient, not, you know, not painful at all. for them, maybe a couple days of some pain medicine or a couple pills. And, half my patients take just, ibuprofen, Tylenol, and they love it because then they can fit it in shoes. And, it's a pretty easy recovery, for them, about 6 weeks. So it's such a wide first metatarsal that I think you can get a good translation, and you're not going to have any, issues with healing or any kind of, issues with the implant. So I think I would decide on a MiniBunion in this case, and also fix the hammer toe.
How about you? Dr. Young? What are your thoughts, sir?
Yeah, I mean, the only reservation I would have would be the partially correctable first MTP, because if you're not going to get a full correction, it does make you a little cautious. But when they're 78, you have a tendency to say, if it's literally just the eminence that's bothersome, and you feel like they can heal an osteotomy, I think a MiniBunion is a great procedure. If you're at all worried about osteotomy healing, then maybe Aiken lateral release and a silver, might be a better option. But I think if you're not worried about cystic changes of the met head, or they don't have any vitamin deficiencies or anything like that, albumin's good. Other than the fact she's a nurse and she's going to change her dressing every day, that's probably the biggest fear I would have. But other than that, it's probably MiniBunion.
Dr. Miller, would you just fuse this and be done with it, or
That's not a bad option. But this lady, first of all, I lay a lot of crepe with this lady. She's got metatarsus adductus, and you see some changes in the second and third, and a little bit of the fourth metatarsal shafts, consistent with some overload with the adductus. And we've always been arguing amongst foot and ankle surgeons for so many years about what you do with an adductus and how you correct anything. You can't really do much of a proximal here to get it corrected, because you have to move 2 and 3 over as well. So at 78, I'm a big fan of the KISS principle here. I'm going with the MiniBunion all the way. And a second hammer toe, maybe second wild to bring that down, whatever you need. But definitely the Mini, we should do great with her. I've been really fascinated how well my older patients have done with the Mini.
Yeah, I kind of did what you guys were stated. This is 2 weeks post-op. The right photo or the X-ray is at 12 weeks. We did a MiniBunion. I did do a lateral capsular release, which a lot of times I don't do, but I did need to kind of mobilize that first MTP better. And after that release, it moved fairly well. I did a hammer toe with the PIP fusion and then Z lengthening, but luckily she reduced reasonably well. And then dorsal capsular release. She did very well at 12 weeks. She was very happy. We were getting some good bony fusion. Sesamoids are corrected well, and then she's very happy with the results.
Agreed.
Looks good, David.
I think Dr. Young, I think you're up next, sir.
Yeah, I'm excited to talk about the MiniBunion. That's definitely been something I've been using quite a bit here for a while. So this is the MiniBunion. They've added a couple of things like this Viking apparatus that they're showing here, which is pretty cool. And there's definitely some good options for how to repair this and help stabilize it, so you don't need 3 hands basically. It's definitely an MIS system. You're not going into the joint at all, which is really, really nice for maintaining the joint function. It's still a very stable construct. You're not trying to shift this thing 100% plus, but you can get a pretty good shift with these things, which is really impressive. And then here's those 2 new things I was talking about, the Viking ship here on the left, and then the new cut guide on the right, which is nice because it's one less thing you have to do. You don't have to replace all your pins and your cut guide a couple of times. That you just you get your pin placement perfect, put your cut guide right over it, and you're off and running. So we'll do the quick little animation here. First and foremost, you want to make sure you're in line. First few times you do this, you definitely want to make sure that you have your orientation correct. So here they're showing the joint in relation to the toe position, and then here you want to make your osteotomy parallel to the joint line. that's what they're showing there. That bisection tells you where you need to make your osteotomy. So that's where you place your pin. Check your pin position on fluoroscopic views, make your incision. Incision, first couple of times you do it, you want to do about 2 centimeters. As you get more and more experience with it, you can shave that down to about 15 millimeters. Here they're showing 2 different sizes of implants. I think the short is almost universally used, but you can use a long. Here's the cut guide being slid over the wire. These are just temporary fixation wires that keep the osteotomy in the perpendicular plane. Here's the Viking ship going on. You definitely want to do this before your osteotomy. I've made that mistake, and that's not fun. Cut the bone, and then you can reduce or remove your cut guide. And now you've got this free in all 3 planes osteotomy. When they're putting this together on the back table, you also want to add this little nitinol suture passer, which is really nice. It will help you out at the end. I used to not use it. Now I use it all the time. Here they're showing a starter hole for for finding your placement of your plate. You can also kind of free up your capital fragment a little bit when you do that. You want to make sure you're parallel. You really want to be, and I'll show some other tips and tricks to this later, but it'll, the more oblique within the canal, the flatter that will be, and you want to be just behind the flare of the bone. Here they're just showing all the different planes that you can correct. And then this is the oblique proximal screw guide, which is nice because it sticks out on the proximal side on a radiograph, so you can see where it's coming out at. You want to drill this just beyond that lateral cortex, and then you really don't want to get too crazy with the tightening of the screw. You just want to put it in until it's purchasing the cortex at first. Viking ship goes back on. You can reduce the frontal plane, transverse plane. You can get some proximal pull on it if you want to. You can really, it helps a tremendous amount. And then when you can pin it here like this, now you can let go of the system, which is really nice addition, because before you couldn't. Here's the locking drill guide. Drill and fill just like you would normally do. I like to go bicortical with these. Obviously, there's lots of different schools of thought on that one. So they put that distal locking screw in. That's going to hold your capital fragment. Video froze on us. Maybe that's the end. And then they're just showing here at the end that they're going to tighten the oblique screw at the proximal aspect. So this is a lot of my tips and tricks for using the MiniBunion. Pre-op planning, you want to make sure that the shape of the head doesn't have a large medial eminence, because if it does, it's going to be hard to reduce the hallux over. You might have to do an Aiken, or you might have to open up the medial capsule to take that down. So there's definitely something to think about when you're looking at that shape of the first metatarsal head. Dissection technique is really, really simple. You basically just make an incision barely through the skin, and everything else is pretty much done bluntly. I use a hemostat or a freer elevator to free up the extensor hallucis tendon, and then I create a little pocket on the plantar distal side for the metatarsal head, for the implant to sit in there when you're reducing the capital fragment. I find that kind of helps it sit more flush against the bone. When you're planning your osteotomy, if you're too far distal and you have a large medial flare, sometimes you can sit on the flare and then you end up with a little pocket between the plate and the capital fragment. That will move your capital fragment more than desired, and can definitely be frustrating. So that's something to look at when you're looking at where to put it. As far as plate placement, when I first started doing these, I thought a lot about, even if you get good bony apposition, if the proximal stem of your plate is too parallel in the shaft, that it might teeter-totter a little bit. So I always try to kind of put it in sort of dorsal distal to plantar proximal, just the way I like to do it. And then kind of showing in this illustration over here, if you've got medial cortex contact distal and proximal cortex laterally, you don't get a lot of transverse plane malpositioning of the head. Whereas if you're perfectly parallel in the shaft, you can get more shift, but you can get the obliquity of the head a little bit. Or you can tighten the oblique screw too much, which will do the same thing. So just little tips and tricks to look out for on that. When I stick this thing in there, it's as oblique as you can possibly get it. And then I just slide down the lateral side of that cortex proximally. And then over here on the bottom left, you can kind of see, I don't like to make my screw too parallel or too close to the osteotomy. So I always shoot it a little more distal. So you'll see a lot of my x-rays kind of have this more distal shot on the distal screw. Over tightening, I kind of mentioned already, you can see, here how it kind of toggles the head over and moves that head in a lateral direction. So anyway, here's one of my cases. Speaking of nurses, this was a pre-op nurse in my old PACU. She had a previous calcaneal fracture and like 4 surgeries before she finally was able to be functional. With the subtalar fusion, you can see they even left a little bit of the original calcaneal plate in there. I'm sure that was a lot of fun. But she came in pretty much just complaining of medial eminence pain. And she had a bigger IM angle, wanted to get back to work as quickly as possible. And other than that, 51 years old and pretty healthy. So I'm going to start with Dr. Oji, see what he would do in this one.
Yeah, I mean, it looks like the IM angle, maybe 16 degrees or so. It seems pretty reasonable, maybe a little higher. I mean, the joint looks fairly good in terms of the MTPJ. I think given her age, I would actually probably toward a lapidus. I think that would give it great fixation and stability. Although I do think she may actually go well with the MiniBunion. I mean, I think both types of fixation are fine. I think you just have to make sure you do a really significant lateral shift and translation for that. You may need to be a little more proximal with your osteotomy if you're doing MiniBunion, but I think both will work fairly well. I think she wants to get back to work earlier, and that's her main goal. I would stick with the MiniBunion, honestly.
Yeah, I like those points. Dr. Miller, what would you do?
Ted Hansen is yelling at me. This is an obvious first MTC fusion. With her hind foot morbidity, the angle of that talus and everything, I think I'm going to go for stability. I'm going to do a DynaBunion on her. And distal release, I think she'll do fine with that. This is going to be a tough foot. She's going to have a lot of stress in that foot that I'm a little afraid to do a mini on her. I'm going first MT. I'm going lapidus on her.
Gotcha. Yeah, I think I know where Dr. Lamm would go on this one.
That's right, Evan. I think, well, if you don't have clinical hypermobility and I don't see anything radiographically that's telling me that there's, any kind of hypermobility there, I think she's one of the nurses, like you said, in your OR. I think I would probably go with, more kind of straightforward procedure, something that, she probably won't have too much pain and it'll heal pretty quick. So I would do the MiniBunion on this. That would be my choice.
Yeah, and I echo a lot of the thoughts that Dr. Oji actually brought up with the whole thought about if you do a MiniBunion, you got to go a little more proximal. So I actually went pretty proximal in this one. Really kind of the selling points for her were the quicker time off of work and quicker recovery type of thing. I also didn't like the idea of fusing multiple joints in the foot if I didn't have to, and she was very, very stable in the midfoot. So I understand the thought, Dr. Miller, to fuse it, and I definitely did bring it up to her. I thought that was not a bad option at all. I was very on the fence with this one, but she really did marvelously with the MiniBunion and ended up getting like 4 more cases out of the other OR nurses out of this one. So
I've been laying a lot of crepe when I do these MiniBunions, because to be honest with you, it's kind of a new frontier. And the MIS surgeon has been getting a lot of press with doing the percutaneous things, but this is more controllable to me. And I've been amazed what I can do when I can spin that head around, how well things do reduce. So yeah, I think it's going to work in these, but it's a new algorithm for us.
Sure.
Dr. Young, when do you do when do you use the tissue or suture to placate the medial capsule, and when do you do a lateral soft tissue release?
Yeah, I pretty much evaluate the lateral structures on every one of these. Once I get it all fixated, I kind of take my hands off of the foot, see what plane the hallux moves in, whether or not to do an Aiken versus lateral release. If I do the lateral release, I'm going to do the medial plication, just because I feel like that really gives you that much more stability. And I used to not do the medial plication hardly at all, and I have really been using it much more frequently. I would say probably 80 to 90% of the time at this point.
And the suture do you use for that? Just like a Vicryl, or what are you?
I use an O Vicryl and a CT, the biggest needle they have. I just grab as much medial capsule as I can with that percutaneous throwing box technique that they show in the technique guide. So, which I've actually used on a few Taylor's bunions too, and it actually works quite well. So.
But I haven't done that yet at all, so I'm learning.
Yeah, trust me, it was all trial and error. So, so here's another one. This was a lady in her 50s. She's got a lot of deformity in the foot, obviously, with kind of a skew foot, but really all of her pain is just bunion pain. She did have a pretty mobile foot, pretty flexible type foot. Yeah, I guess I'll start with Dr. Lamm. What are your thoughts on this one?
Yeah, so definitely looks like some midfoot, slight midfoot collapse there, maybe. Definitely, that skew foot type appearance is concerning, that she may have some hypermobility. And of course, the metatarsus adductus a little bit. I think that, being 57, I think that, depending on how active she is, some patients are, really looking to just kind of, get in better shoes and, walk the dog kind of thing, versus other people really wanting to get pretty active. So I think that plays a role in what I might do, because you don't want to have, a mini bunion kind of come back with patients having pain down the road if they have that hypermobility or flexible foot. But I think if it reduces well, the first MPJ, then I might consider a mini bunion myself, just because you could get the shift pretty good. But I worry about the hypermobility on that. But I think I'd do a mini bunion in my practice.
Gotcha. Yeah, that's why I called on you first. I thought that might be your thought on it, but I was kind of, I don't want to give too much away. I'll see what Dr. Miller has to say.
Well, I really like you presenting these lunatic fringe cases. It's kind of fun. This patient obviously is a triple arthrodesis and first MTC fusion. And if she's not willing then to go to that big surgery, then you talk about just doing a mini bunion, but she'll be back. That first MTC is not stable, looking at that x-ray. And that she's going to have further deformity. I'm afraid if I do a mini bunion, she'll be back in 5 years for her instability, and we're going to need to do something major then. So I tell the patients what you need is to straighten out your hind foot and to straighten out your midfoot, and we can just do a distal soft tissue procedure with that. If she's not willing to go non-weight bearing, you can do a mini, but she'll be back.
Yeah, Dr. OG, your thoughts?
I would go with a DynaBunion 100% this. I agree with Dr. Miller. I do feel that there's instability at the first MTC. I do worry about recurrence risk with any type of distal procedure. Yeah, definitely DynaBunion. And I typically do an Aiken as well for pretty much all my patients. And if she's very reducible, I probably wouldn't have to do a lateral soft tissue release or medial plication. just a nice reduction through the DynaBunion and the Aiken, and that's probably all she'll need.
So David, how much of her pain is coming from that unstable hindfoot?
Yeah, I mean, I don't know if I would do a triple unless she has pain related to that. If her pain is really at the hallux, I think it'll be a hard sell to do any type of hindfoot procedure for that patient.
Yeah, the one thing that I didn't share in the history on this was that she did have a significant Achilles tendonitis as well, and a pretty significant gastrocnemius equinus. So I did do a gastroc recession as a way to try to mitigate some of the deforming factors. But I just did a DynaBunion on this one, tried to get her a little plantar translation on the first metatarsal, and then coupled that with the gastroc, and that seemed to help out the rear foot a little bit. She cured that Achilles tendonitis almost faster than she did the DynaBunion. So she ended up doing great.
That's fascinating. That's beautiful how they corrected the hind foot. Very nice.
Yeah, I like
Yeah.
the plantar translation of Dr. Yang. I mean, I think that helped with the pes plainness and improved the hindfoot alignment very well.
Yeah, this was back when I was even trying to move the plate a little more plantar to see if I could get some plantar compression as opposed to dorsal compression. I've kind of gotten away from that a little bit just because I don't think it really added enough to kind of make your incision bigger and everything else that you had to do that. So I've just now I go straight medial, but it worked out really well, really nicely on this case.
I found that's not been helpful at all, Evan. I know there was some press about that with some of the other systems and getting, but we were at Union, we worked with plantar plating years ago, and it really mechanically didn't help all that much.
Mm-hmm.
And especially when you got a stable compressing things, I've gotten beautiful fixation just gone direct medial with this, and it's been fine.
Yeah, that's my technique now. I totally agree with you.
Evan, it looks like you had that synostosis there too, a little bit between 1 and 2. That looked good as well. So
yeah, I've gotten into doing that just about every time. I do like you do. I open it up. If there's a little cartilage surface there, which there is probably about half the time between 1 and 2, I'll take a curette to that and then just punch 1 or 2 holes with a 1.8 or 2.0 millimeter drill bit. And that's usually all it takes.
great. All right. Well, I'll take it from here, Evan. Thank you. And I'm just going to run through some cases here. I know we're getting short on time, so I'm going to just kind of give you the rundown here. This is a 47-year-old patient of mine, a female with 10 years of bunion pain. She waited a long time for the surgery because she heard it was so painful and problematic for her aunt that had it done many years ago. And so she was kind of very hesitant. You can see a pretty large IM angle, not really any hypermobility. On my exam, I kind of load the hallux and then I'm pushing on the plantar aspect of the first med head. And so let's go. I ended up doing a MiniBunion on this case and some percutaneous MPJ capsulotomies on the lessers. I got pretty good shift. I take that little medial eminence off the shaft of the first metatarsal to see how I kind of shave that down with a little small saw blade. And then you can see I got the bicortical purchase distally, got the rotation corrected. And this is kind of media post-op 1 month, and then I think 2.5 months to 3 months after surgery. So it does take a little while for that bone to fill in laterally, but because the periosteum is intact laterally, you get that to fill in real nicely. So
Brad, how big a shift can you go? Joel Vernois is talking with the perks that he's getting 100% shift, but I think it's crazy. Yeah. This is a 70%. This is a big shift.
Yeah, so I think you can get these big shifts and they fill in just fine. The nice thing is this is it's an intramedullary, it's stable, and it's also very stable with the locking screw distally. So I found these are significantly stable and that you can shift them 70, 80, 90%. And I have shifted some that are almost off connected. and they still heal very nicely as long as the stability is there with the implant. So it's pretty amazing. And I am kind of pushing the limits, as you mentioned, Stuart, when I'm getting into the, older patient population, that I don't want to get involved with the Lapidus with them, and they just need to kind of get into nicer shoes and get some comfort over the large eminence. So I think that's the population that I'm kind of pushing the limits of the translation. But the younger ones, I'll go to the Lapidus if I think it's, real significant.
No, this is great. I've done this. I was going to say that's the perfect candidate for the MiniBunion. They're afraid of the surgery, and they, to a person, they've come back and said, "I can't believe how much it didn't hurt me."
Yeah, so she sent me a picture. She was running a mile in 2 months. She was running a mile. And then at 2.5 months, she was snowboarding. And then she sent me all her friends from Palm Beach ever since, because she's in some book club. So she's like, "Oh, it didn't hurt me at all, Dr. Lamm. It was great," So it's very powerful, not only from a procedure standpoint, but the patient doesn't have much pain, and they really like you, and they think you're great because you made a small incision and fixed their big bunion. So next case is a 48-year-old male. He's pretty active. He's got hallux valgus with hypermobility, and not really any. He does have that metatarsus adductus a bit, and he's got that. Looks like maybe the second met cuneiform. I don't really have all the X-rays here, but it definitely was bothering him dorsally there as well. So I was, for him, like I said, he had clinical hypermobility when I was doing my subjective exam. So again, for time's sake, I'm going to breeze through it as what I'm going to do here. And I did the second TMT fusion with a staple, single staple, and I did my DynaBunion with the locking or the cross screw there to kind of hold it all together. And this worked out great for him. He was from out of state. He came to me, and I had him walk in. I had him in a cast, I think, for 3 weeks, and then I started walking in a boot, and he was just fine with this. So it's pretty amazing how strong, as Stuart mentioned, these nitinol staples are. Now they have kind of larger bridges that CrossRoads has made, so it's even stiffer and even more stable than these kind of thinner ones that we had in the past with other companies and so forth. So he was real happy with this, and healed up well. He's an extremely active guy, and he got back to, I don't know, I think he was like a mountain biker, rock climber, and he was 2.5, 3 months, he was back on the trails and on the mountain.
Awesome. Looks great. I love how the metaductus looks much better too. Just getting that IM angle closed down, you can really, I think his whole foot's going to function a lot better.
Yeah, and he didn't have any changes on MRI on number 3, and nor did he have pain. So as Stuart said, the piano test I used to kind of see if he's painful clinically, but it was just 1 and 2. So that's what I did there.
Dr. Lamm, did you, on one of the proximal screws, is that intentionally long to go into the intermediate cuneiform, or?
Yes, so I did do that. I like to do that when I'm doing this construct here, when I'm doing 1 and 2 together, and I kind of, as mentioned before, get into that inner cuneiform space a bit, as well as the inner metatarsal space at the base, to try to create one large fusion mass there.
You prepare that joint surface and the intercuneiform articulation?
No, I didn't prepare the inner cuneiform joint surface. I mean, I might pass a curette if I can get it down there, but I typically feel it's stable enough if I'm putting a screw across it. All right.
A question from the audience about a PT protocol after bunion surgery. I definitely have, I don't have a specific protocol. It depends what they need. I work on their range of motion and mobility and gait training, especially for these DynaBunions. They need to learn how to walk again. Any specific PT recommendations that you folks have?
Yeah,
I hide them from physical therapy until I feel like the fusion has taken place, and then I let them start going and doing all that kind of stuff. Because I've had too many TMT joints going to non-unions from physical therapy.
Yeah, likewise. I don't have anything specific. I just kind of see where they are around 8 to 12 weeks. And if they're kind of falling behind in terms of range of motion and function, and I start PT, but I find that 70% of the time I don't have to do that. They just kind of go back to their own activities.
Yeah, I think, if we're not opening the joint here with the MiniBunion, or sometimes we don't have to with the Lapidus either, the DynaBunion. So I find I'm sending folks less and less to physical therapy because we're not, having those joint stiffness issues. But if I do notice something, I'll send them.
I find that for my older patients, and again, I'm using a lot of these MiniBunions on older patients who are less mobile. I send them therapy just for gait training and learning how to walk better. I think that's very helpful in terms of long-term outcomes. But otherwise, no specific protocols.
Great. Yeah, and this was just the last case of mine, another patient, just showing the progression of how well that lateral bone and regenerates, and that patients get great function. You can see on the bottom right picture there that small scar, good function, and they're happy. And if you remember the studies, the clinical studies show that patients, they really want to have no pain and function well. And then, kind of third on the list is the cosmesis, but I think this kind of hits all three for them. All right. I think I'm going to turn it back over to you, Dr. Miller, for some final thoughts if we have time.
Sure. So that's pretty quick. Any questions from anyone else in the audience? While we're waiting for that, certainly a couple, we mentioned that grater blade that they have now. It's kind of cool. It's looks like a cheese grater. You put it on the oscillating saw, and you can use it all kinds of places to smooth down your bone. Highly recommended. Let's see. Oh, I had a question for the whole panel here, because no one's answered anything yet, is when I'm doing my DynaBunion, a lot of times I won't even put the distal frame on. I'll just push the toe over on my own. And what do you think about that? When pushing on the first med head.
I think you definitely can, but I think the big advantage of that system is that you can let go of it and everything stays in place. If you're, that's the thing that I like the most with all of this instrumentation is how much easier it gets to free up a hand, with the Viking ship for the MiniBunion or for the, for DynaBunion, to put that rack block on and then put the IM reducer on there. You can let everything go and it's not going to go anywhere.
I think it's a great point, because I hated Lapiduses for so many years because I could do it with a fellow hand, with me holding the foot, the fellow putting the screw in was easy. When you only have one set of schooled hands, things get very difficult very quickly, even just for the regular bunion. And the main benefit of the Viking ship for my MiniBunion has been I can take a look at this on the C-arm a few times. I can look at that neck, make sure I didn't pop it up or down a little bit. And so I've been pretty happy with the instrumentation, to be very honest with you.
Yeah, I think the DynaBunion follows the deformity principles as well, because what you do is you first rotate the metatarsal, then you angulate it, and then you compress it with dorsiflexing the hallux, and that follows the same principles we have for osteotomies and deformity correction. You want to rotate first, then angulate, and then you can compress or translate or whatever. So I think it works slick, as Evan mentioned, and the instrumentation has been really helpful to allow you to get it done nicely and accurately. And the cut guide is it's called the uncoupled cut guide. So you cut one side, then you flip it, cut it the other side, and you cut less bone and get less shortening with that cut guide, rather than some other cut guides that are, you're taking a wedge of bone out, which is a lot more bone removal, and that's creates significant shortening and problems.
Really impressive how little bone you're cutting with that. I think it's less than 2 millimeters, so it's really impressive.
A question from my friend in Colorado, wondering whether anyone does bilateral surgeries with a MiniBunion.
Yeah, so I have tried it. A few patients of mine, and I keep them off the feet longer. Don't let them weight bear like I do post-op day one if for it's a unilateral case. But I try to talk patients out of it basically in general because they get much more swelling, and it's, as we know, much more difficult. But I think you can do it if you have the right patient and they understand that they need to be off of it so much more, and it's not as straightforward as they think.
What do you think, Dave? Bilateral minis?
No, I mean, I'm with Dr. Lamm. I think patients really underestimate the difficulty of post-operative, especially with both sides and pain control and swelling. So I personally talk patients out of it. I don't think they have a clear idea of what it really involves to have both feet operated on.
I'm liking this. Evan, how about you? Ever do bilaterals yet?
I have not done one, and I don't think I ever will. I've had to talk a few patients out of it.
I am so grateful for that question because
the first thing I do
like
is
the old dinosaur, and now I realize that I'm the trailblazer. I've done it twice. My second one was just in the office this morning. I did bilateral minis. I did a hammer toe, and I did bilateral Kramers on her, and she is happy as can be. I let her walk on both feet with post-op shoes, and so far so good. My N of 2. And not bad. She was a pretty healthy lady, but so I have done bilateral, but again, a degree of caution. I recommend doing one at a time when you can.
Yep.